Thank you, Jashila, for the introduction, and I'd like to thank yourself and also GenesisCare for providing me with the opportunity to give this webinar today. I'll be talking about some of the more recent research, which I consider to be quite significant. It's from a lot of it's from our own group, but also from others that I think are changing the paradigm considerably. So, firstly, exercise medicine, and many of you will have seen this slide from me before, but I think it is important because it gets across a very important point that increasingly exercise is being recognized as a medicine, not physical activity. It's not a lifestyle choice. It's an actual medicine. And it's the physical assessment and prescription of exercise, specifically for the prevention or treatment of injury or illness. Now, exercise oncology is specific to cancer management. Now, I believe that we can call exercise a medicine, and the reason why is it drives enormous chemical changes and structural changes within the body, and this, of course, is the purpose of pharmaceutical medicines. They are taken to create change within the body, and physical exercise does the same thing. It creates enormous shifts in hormones and cytokines, also immune system responses. It drives direct structural adaptation and repair. It changes quite markedly blood perfusion and causes vascular adaptations, and as we'll see, I won't present today, but it's a very important work there in terms of changing the vascular structure, blood perfusion, oxygenation within tumours to enhance the effectiveness of chemotherapy and radiation therapy. And it also, if nothing else, it increases the physical and mental resilience of the patient, and that's just so important to help them to get through this journey. So I apologise for the quite complex figure here, but this is from a paper led by one of our PhD students, Jinsu Kim, and it's in press now with Nature Reviews Urology. It should be out in the next few weeks. But in this paper we summarise the potential effect of exercise and how it systemically alters the environment within the body to create a anti-tumour benefit. So if we have a look at exercise here, when we exercise, of course, our muscles contract, and when they contract, they produce what are called myokines. So these are cytokines specifically released from muscle, and then these travel through the systemic circulation, and of course they target the tumour as well. Now this then has a series of effects, and I'm going to talk about three. We published a paper some time ago where we outlined around 12 different mechanisms by which exercise actually suppresses tumour development and actually alters cancer cell biology. But I'll just present these three today, which we've gone into much more depth, of course, in this review in Nature Reviews. So there are the direct effect on the cancer cells themselves, and it's through these particular myokines, decorin, OSM, irisin, spark, IL-6, and we see some direct effects here. For example, decorin acting through here to actually increase cell cycle arrest and reduce proliferation, and then acting through to increase apoptosis as well. We have a pathway by which irisin actually reduces EMT, so it reduces the tendency of cancer cells to actually metastasize. IL-6 chronically actually can increase prostate cancer cell proliferation, but acutely produced through exercise, it actually has a suppressive effect on prostate cancer cells. And that's what makes it so complex, because these myokines have different effects depending on how they're actually being produced, at what times, and through what mechanisms. Another important way in which exercise does tend to suppress the tumour positive environment is through its interaction with the fat tissue in the body. And this is a problem because, well, it's not a problem, the exercise effect's not a problem, but the having a high level of body fat, this tends to cause systemic inflammation, chronic inflammation, and through this it really creates a pro-cancer cell environment. And it's a key reason as to why we're seeing increased incidence and increased aggressiveness of many tumours. But when we exercise, again, some key myokines here stimulating and signaling for changes. So we're seeing through the GLUT4 pathway here the reduction in hyperinsulinemia, increased fatty acid oxidation, and improved insulin sensitivity and glucose uptake. And that's reversing then many of these effects of sedentary behaviour and the being of high body fat. A number of other mechanisms here. I won't go into more. If you want more details, please contact me. I can send you a copy of our paper when it becomes available. Increasing glucose metabolism and reducing, again through myostatin here, and insulin resistance, fat accumulation, increasing lipolysis. And other mechanisms here you can see where it's starting to, the exercise is actually suppressing this adipose and adipocyte pro-cancer environment. And then finally, I just want to talk about the effect of exercise in terms of anti-tumour immunity. And this is receiving a lot of research and proving very, very exciting, but the majority of work so far has been in animal models. But we're starting to see more and more translation across to actual clinical models in humans. So one of the mechanisms here is when we exercise, of course, we produce a lot of catecholamines, and this is tied very closely to the intensity of exercise. And I think this is a key point, take-home point here, that intensity of either aerobic or resistance exercise seems to be very, very important, and in many ways more important than volume, because with higher intensity we produce a surge of adrenaline, noradrenaline, epinephrine, norepinephrine, targeting the liver, and then the mobilization of natural killer cells into the circulation, and then they, through the action of IL-6, infiltrate the tumour tissue here and provide obviously an anti-cancer effect there. Now we also have the influence of IL-15, IL-10 here, causing increased proliferation, increased survival of these cells, and increased effectiveness of memory T cells. So it's really not only increasing the concentration of these very powerful anti-tumour immune cells, but also their effectiveness and their surveillance is being improved as well. And the overall result, also through increased blood flow through the tumour stimulated by exercise, an increased number of natural killer cells and T cells per gram of the tumour tissue. And this has been demonstrated in a number of our animal studies here, with a considerable suppression of tumour progression. So I just want to give a few examples of our more recent work. This particular study is called the interval GAP4, stands for intense exercise for survival among men with metastatic castrate-resistant prostate cancer. So these men have been through a range of different treatments. They are now palliative. There is no cure for their cancer, and it's one of only 3 randomized control trials, phase 3 that I know of in the world, which is actually testing whether exercise medicine can increase survival. And I acknowledge the support of the Movember Foundation for funding this to some $10 million. It involves trial sites around the world, approximately 20 trial sites currently across 10 countries. We have over 100 patients recruited to date, and importantly, we have had no serious adverse events. So these are men with advanced cancer, and as you'll see from this next slide, the actual exercise intervention is quite intense. We are using high intensity resistance training, high intensity cardiorespiratory training, including high intensity intermittent or interval training as well. And we've powered this study to try and determine if there is a survival benefit. Currently, the median survival for these patients is around 35 months, and we're powering the study to see if we can extend this through exercise intervention to around 44, 45 months here. We're looking at some secondary outcomes, time to disease progression. We're also doing a whole lot of biomarker analysis around some of those parameters that I showed you in the previous slide. The exercise group, fairly well supervised, or highly supervised exercise over a 12-month supervised program and then 12 months of home-based exercise. The self-directed arm here receives the exercise recommendations from ACSM, and then some psychological support around newsletters, etc. So I just wanted to give you an update on this trial. We have around 104 patients randomised across 14 sites at the moment. 13 are in the first year, 35 are in the second year. 48 are now in follow-up. 8 have withdrawn. 22 are now deceased. 6 in the first year, 7 in the second year, 9 passed away during follow-up. 9 deaths are in the intervention and 13 deaths in the control. We can't make any statements about survival as yet. We just don't have enough patients through the trial as yet. I think importantly to note, there's been no serious exercise intervention-related adverse events. So let's have a look at that. We have had adverse events, as you'd expect, working with a patient cohort such as this with quite advanced disease and undergoing quite difficult treatments. And the majority are grade 1, so low-level adverse events, about 51%, grade 2 about 39%, grade 3 only 10%. So, but these events are not related to the trial. They're just events that occur with the patients just through the decline in health or the side effects of treatment, etc. So if you have a look, are they related to the trial? Well, 67% are unrelated, and a further 16 are unlikely to be related. 10% possibly, and 7% probably related to the trial. Now, these adverse events, as I said, no serious adverse events related to the exercise study. Most common was pain, muscle strain, pain in bone, pain elsewhere, such as joints, fatigue. One patient had left knee swelling and tenderness, and one patient vomited after the CPET. So we do a cardiopulmonary exercise test to maximum. One patient vomited afterwards, but he did reveal that he had quite a large meal very shortly after the test. So we've commenced the cancer biology research out of GAP4, and this data hasn't been published. This is just fresh out of our laboratories here. And what we did was we took blood at baseline and then at 6 months of the exercise intervention. This is the data just for the exercise group, the control group here, sorry. At baseline and post 6 months, and this for the exercise group. So we have a look here at Spark relative to body weight. We see a decrease in the control group, and it's maintained in exercise. And OSM decrease in the control group and actually increase significantly in the exercise group. No changes yet in Decarin. Now, so we're seeing some interesting myokine changes. And remember that this is in patients with advanced prostate cancer. This has not been done before. Previous research has either used healthy individuals to do myokine studies, or they've used patients with stage 1 to stage 3 disease. So that's what's happening in terms of the myokines. But let's have a look. We then took their resting blood. We extract the serum, and then we actually expose cell lines. And these particular cell lines are DU145 cell lines. So these are castrate-resistant prostate cancer cells, because these men are all castrate-resistant by this stage of their disease. And very interestingly, what we're already seeing is some reductions or differences here in terms of the rate of growth of the cell lines. And you can see the top line here is for the control group, and then here in the lighter blue, this is the rate of growth for the exercise group. And we look at different time periods here. 24 hours, significant difference. 48 hours, but no difference at 72 hours here. If we look at the area under the curve though, we see significant suppression of prostate cancer cell growth across all of the time periods. Now, what's important to point out, this is using resting blood. Most studies have used immediately post exercise blood. So we give them an exercise session, and then we draw blood, and then we use that, and that's what most of the studies have done. This is resting blood, and so it's encouraging to see that we have these very beneficial anti-cancer myokines present in the blood, the resting blood of these patients, and it has a suppressive effect on the rate of growth of prostate cancer cells. So very interesting results. We're now extending this by looking at the acute exercise effects in these patients. So hopefully I'll be able to present that to you at a later time. So changing tack again, this is recent work from, again, one of our PhD students, now graduated, Dr. Rebecca Wilson. And this particular study was a very pragmatic study, single group, where we were looking at overweight and obese patients who have prostate cancer, and we were preparing them for robot-assisted radical prostatectomy. The problem is that these men, being quite obese or overweight, is that the surgery is quite difficult, and there's a much higher risk of complications both during surgery but also post-surgery. So we looked at patients where they were put on a very low energy diet, and the duration varied. It depended on when their surgery was scheduled. They also did 90 minutes of aerobic exercise per day. The entire goal was to try and drop their body fat as rapidly as possible and try and reduce systemic inflammation. So here are the results. In terms of total body weight was reduced, total fat mass reduced by 5 kilos on average, body fat percentage 3.1% reduction, trunk fat, visceral fat, nice reduction there. Great news. Problem? Total lean mass also decreased by 2.4 kilograms. Appendicular skeletal muscle mass 1.2 kilograms. So this is problematic. Although we did achieve a fantastic and highly beneficial loss of fat mass, they also lost lean mass muscle. That's a problem because we know from an extensive number of studies now that low muscle mass for cancer patients is highly problematic. Their prognosis is much worse. If these men then have to go on to other treatments, in particular chemotherapy, we know that they'll have higher side effects if they have low muscle mass. We know that their overall survival will be compromised. We have to hold muscle mass on these patients. So these are waterfall plots showing the variation in responses that we see here. And we see that most of the men do lose fat mass here, but there is quite a variation in terms of how much they're actually losing. Some are losing up to 10 kilos, you can see, of trunk fat or overall fat mass here. But pretty much every single patient is losing lean mass and appendicular skeletal mass. And this is a problem, as I've said. But I do point out, in that study, we did not have any resistance training at all. Now, Rebecca, Dr. Wilson now, I better call her, followed up the study with a 12-week intervention in obese men with prostate cancer receiving androgen deprivation therapy. And they did complete 300 minutes or more of aerobic exercise per week, but they also did resistance training. Considerable energy deficit again, which you can see there. The purpose of this study was to say, okay, with these men, can we reduce fat mass whilst maintaining muscle mass? And these are the initial results here. We see that they increase in strength quite markedly, so they respond quite well, even just to a 12-week intervention, increase in upper and lower body strength. But also their cardiorespiratory fitness increased quite well, also relative and absolute, which is great. These are great improvements in fitness, and this will really help the patient. But let's have a look at the loss of total body mass here. These are individual patients here. And you can see one patient actually increased body mass, but the majority lost body mass, and the majority lost fat mass as well. Trunk fat mass was reduced in most patients, and visceral fat, very important also for metabolic health, was also reduced. Now, what we did show was no decrease in lean mass, but that was the average result. The average group result was no change. But if you have a look at these two graphs here, some patients maintained or increased lean mass quite considerably, but around half actually lost lean mass. And so this is still a problem. And we really have to become much more sophisticated in how we do these exercise prescriptions, and also perhaps in some nutritional interventions to try and prevent these patients here from losing, in some cases, 2.5 or just over 2 kilograms of lean mass lost in only 12 weeks. Now, we also drew blood from these patients to have a look and see what sort of changes we might see in terms of their anti-tumour systemic environment. And again, similar to our previous study for the interval gap 4 patients, in these men, they're on ADT here. It's generally early stage disease, but again we saw some very nice reductions. We see here, this is no control group here, but we see the pre versus post training blood exposed to these cells here, and we see If we have a look here, this is the p-value here, significant reduction in cell index at 72 hours, growth rate here as well, significantly reduced. Again, I reiterate that this is using resting blood, not exercise acutely conditioned blood. The other thing I point out that this was only 12 weeks of exercise intervention. I think it's a good time to point out this issue of individual responses, and we have to be very aware of it. When we look at group means, we tend to get a bit more of a rosy picture as to what's going on with these patients with cancer when they exercise. Now, this is a study we currently have in review with neuro-oncology practice, and this is supervised aerobic and resistance exercise in patients with high-grade glioma, so a particularly nasty brain cancer. But also they're undertaking adjuvant chemoradiotherapy, so they're receiving both chemotherapy and radiation therapy for their cancer. Now, we see across this is the percentage change across the exercise intervention. Now, leg press, fairly consistent improvement. Here we see they're getting stronger. Repeated chair rise, some of them are getting worse, getting slower, but the majority are getting faster and improving. But we have a look at a time 400 metre walk. Some of the patients are getting faster, some of them up to 20%, but look, we've got several patients that are actually getting slower, and one is getting 70% slower. 6 metre walk again, this same patient again here. We see a bit of a spread here in fast pace and tandem walk tests here. I'm just trying to impress upon you the huge variation in the adaptability, the response of these patients. And it really depends on their progression of their disease, but also how they're tolerating the various treatments that they're receiving. And some you may not be able to prevent the decline, and in fact they may get much, much worse. Now, this brings me to a very interesting paper. Look, it's not overly recent. I tried to present things which are really 2020 or 2021, but this is a very nice paper from 2018 published in Cancer by Jessica Scott, and they're with Lee Jones's laboratory at Memorial Sloan Kettering. But I think this is a very, very important paper, and I really encourage you to read through this one to get more details around it. Because what they did was they looked at a fairly not intense, I'd say, what they did was they tried to implement the ACSM recommendations around aerobic exercise, but this was in women with metastatic breast cancer, stage 4 breast cancer. And so this is the planned, if you have a look at this graph here, this is the planned in dark blue in terms of the METs per week of exercise. And in the reddy colour, this is what they actually did. The total cumulative, look at the difference between what was actually prescribed and what was actually achieved. And then we have a look at the individual patients here. What we see is some can go pretty close to meeting the exercise prescription recommendation, but most of them are lucky to make 70% or 60%. Some struggle to even make 30% of their actual prescribed dosage. And we have to take this into account when working with these patients, both in research but also in the clinical setting. Depending on how the patient is tracking in terms of their disease progression and their tolerance of the toxicities of treatment, you will see vast difference in their capability to actually exercise and respond. I'll move to another study. This is from our group, and this is currently in review in JAMA Oncology, and I acknowledge my co-authors there. And this was looking at the associations of fat and muscle mass with overall survival in men with prostate cancer, and this is a systemic review and meta-analysis. And we have a look here across a number of studies here. We look firstly at low fat versus high fat and overall survival, and there's no difference. So in terms of overall survival, no difference between low or high fat for multivariate or for univariate analysis here. Either that favours high fat mass slightly, but it does cross 1 there. But importantly, muscle mass. We see across these studies a significant overall favour in terms of high muscle mass, both for the multivariate analysis and the univariate analysis here. So I think this is important. Absolutely, maintenance or control of fat levels is important, but we cannot forget the importance of maintaining muscle mass in these patients. This is another meta-analysis from our team we published earlier this year in Medicine, Science and Sports and Exercise. And this is looking at resistance exercise dosage in men with prostate cancer. And if we have a look here, this is comparison of resistance-based exercise versus control, the effects on lean mass. And we see, yeah, it works. Across a number of studies here, we see we've broken it up by low risk of bias and some concern or high risk of bias. There's no difference there at all. We take out Gilbert because there was a problem with that study there, so we've treated that separately. But we do see it's about a 0.5 to 0.6 benefit of the resistance exercise versus control here. And overall effect is significant, about 0.5 kilograms. We have a look at here appendicular lean mass, the same effect here. We get a considerable benefit, about 0.4 kilograms overall there. Now this is mirrored by considerable improvements in strength, which is what you would expect. Here about 3.9 difference here for chest press, leg press 23.5, leg extension and seated row. So if you do resistance exercise in men, if you're a man with prostate cancer, then you should get stronger and you should increase your muscle mass, which is a great outcome. What we found very, very interesting here, though, was that in untrained older men with prostate cancer initiating an exercise program, a lower volume of moderate to high intensity resistance training was as effective as higher volume resistance training for enhancing body composition, functional capacity and muscle strength in the short term. These studies were predominantly 12 weeks or less. So again, I think this is an important take-home message, that it appears that it is the intensity of the exercise which is a key prescriptive factor driving the benefits from exercise, and that we may be able to prescribe lower overall dosage or volume of exercise to help reduce the barriers and to enhance adherence, but still have quite good effects. Now, how this plays out over longer term studies, we need further investigation to determine that once you go past the 3 months, 6 months, etc. But that's important there. Perhaps at the outset, we don't aim for the ACSM guideline of 170 to 150 minutes per week and 2 or more resistance training sessions. In fact, in this particular study, we found that 1 resistance training session per week was non-inferior to multiple training sessions per week. So something to keep in mind for your exercise prescription, certainly with these particular patients. I want to revisit this resistance exercise and lymphedema. I still get some queries, some concerns about patients with lymphedema or at risk of lymphedema performing resistance training. And I did my first study on this particular topic. I think we published it in 2005, I want to say, maybe not, but it was a fair way away. It was so long ago that we didn't even include it. They didn't even include it in this meta-analysis, but it does include a number of our papers with my colleague Professor Prue Cormie here as well, and also these 2 studies here from our group. But why I want to present this is, again, this is a recent meta-analysis from last year, and across these studies, what they're showing in terms of bioimpedance, so actual change in lymphedema status of these patients, there's no adverse effect of the resistance exercise. It does not cause or exacerbate lymphedema. In fact, overall, across all of this entire meta-analysis model, we're actually getting a significant benefit of resistance exercise in improving or reducing lymphedema. Now, also, of course, what you would expect is an improvement in upper extremity strength. So that's very, very consistent across the studies and a very strong effect here. And also, similarly, for lower extremity strength, some really nice benefits. So based on this, look, clearly the recommendation is that patients with lymphedema should perform resistance exercise. Sure, monitor them, check for exacerbation, but in the main, we've seen now, quite a good quality meta-analysis, systematic review, demonstrating that it may actually reduce lymphedema and it certainly improves strength. No evidence to date that appropriate resistance exercise, properly monitored for lymphedema, actually causes lymphedema or exacerbates existing lymphedema. And I'll move on to another. I wanted to present today a lot of meta-analyses and systematic reviews, because they are the strongest body of evidence. I think we're at the point now we need to pull a lot of these randomized control trials and even single group studies together, and try and get some some much stronger messages coming across here. And this was a study which was published out of the Polaris collaboration. A very large number of collaborators on this study, pooling their data from many studies, as you can see, I think 23 from memory, and looking at the individual data though, pulling it together, not group data, but individual data, patient data, pulling it together. And what we reported here in this particular study was statistically significant beneficial effects of exercise interventions on fatigue. And there has been some varying in terms of outcomes here around fatigue and exercise, but certainly from this meta-analysis, we've shown some pretty positive outcomes here, and it's irrespective of demographic or the clinical characteristics of the patients, or, got to be honest, even to a large extent, the mode and prescription of exercise. Aerobic and resistance exercise, both effective, and quite a wide range in terms of intensity and volume. Certainly these findings support a role for exercise, preferably supervised exercise, for reducing cancer-related fatigue, which of course is one of the most debilitating side effects of the disease and of cancer and its treatments. So we did find a superiority for supervised, and we can see over here unsupervised, it was not significant in terms of benefit here. It does cross the zero line here, but supervised definitely. Definitely a positive benefit there, quite considerable in terms of reducing fatigue. Interestingly, we found that interventions of less than 12 weeks had a larger effect than those of greater than 12 weeks. This needs more research and to look into why this might be the case. So just something to point out there. I keep moving on. Another study here, again a meta-analysis, a systematic review. And just regarding aromatase inhibitors and the very large problem here of the side effects on the musculoskeletal system in breast cancer survivors. And I just want to present this very quickly, because in this meta-analysis they show that exercise relieves the musculoskeletal symptoms and improves quality of life. This is across 9 studies. All of them included aerobic exercise, and 5 were combination exercise modes, including aerobic and resistance exercise. But we're seeing a very nice benefit here for the exercise group in terms of pain, stiffness of the joints here, and grip strength improved. They did give a total here. I don't know why you total, because obviously greater than 0 here is of actual benefit. So anyhow. And also for quality of life, very nice improvement here in terms of quality of life in these patients. And we're seeing a large number of patients with breast cancer receiving aromatase inhibitors now. So this is a nice and timely meta-analysis. I'll change tack again. I'm jumping around all over the place. This is some very nice, very recent research. This is from one of our PhD students, Mary Kennedy, now Dr. Mary Kennedy. And I just want to take you through some of her PhD work and the resulting 3 publications or papers that came out of her work. Now, this was research done around a co-located exercise clinic, actually within a cancer centre. And this is work with Genesis. So this is work with GenesisCare in Perth, Western Australia. And what we did was we collaborated with them to build an exercise clinic here, 20 metres walk from the linear accelerator, from the actual site where the patients are receiving their radiation therapy. So how did it work out? Well, just in this particular paper here, we published in Seminars in Oncology Nursing in 2020, last year, on safety, effectiveness and uptake. Now, from that period, there's about 1,900, 2,000 patients commenced treatment at GenesisCare. Only 12% actually enrolled in the exercise oncology program, even though it was free. It was freely available, only 12% took it up. 67% of those were referred by just 2 of the practicing oncologists. 2 of them were obviously very committed to the exercise, thought it was important, really pushed it with their patients. 73 declined the study assessments. We had the intervention, but we also asked them to undergo some more advanced assessments of their physical structure and function and performance. Now, it's interesting to see in those that declined the assessments, those who actually agreed to undergo the assessments, when the majority were younger, 58 versus 63 years, a higher level of education, and they tended to be employed. would actually undertake the additional assessment. So I think this is instructive in terms of implementing pragmatically exercise clinics within cancer centres as to how you actually target the patients and how you actually get them engaged in it, as well as engaging the oncologists as well. Now, these are the results from this, and I apologise, it's a very busy table. It's straight out of the publication. Again, I can refer you to this paper. If you want any copies of these papers, please just email me and I'll send them out to you. But look, we see fantastic improvements in speed of walking, cardiorespiratory capacity, chair rise, stair climb, chest press, seated row, leg press, these strength measures increasing markedly. Even their balance improved considerably, we see here. Some improvements in quality of life, global health, nausea and vomiting and constipation. But what's to keep in mind is these improvements or maintenance, so no decline is occurring in an environment where these patients are receiving chemo and or radiation therapy. We would normally expect a considerable decline in these patients. So the next paper that Dr. Kennedy led and published, we published here in the European Journal of Cancer Care. And if you build it, will they come? And this is the evaluation of the exercise clinic. I mean, just co-locating the exercise clinic right next to where the patient receives their cancer therapies does not in of itself overcome the logistical challenges of providing integrated exercise services to people during their cancer treatment. To enhance the utilisation, you need an implementation plan, and it needs to accompany the intervention. So here is over these years from 2013 to 2017, the number of patients, new patients coming into this particular GenesisCare centre, and these are the numbers of patients that actually took up the exercise medicine opportunity here. Very, very low. So in the next paper, and again I'm just skipping through these, there's the reference there. This was published in the International Journal of Behavioural Nutrition and Physical Activity, again with Dr. Kennedy leading this paper. If you want more information on the implementation plan, how this was actually done, please go to the paper here. And we look at the, how this was actually in terms of target adoption, implementation, maintenance of the outcomes here in this very nice table, which pulls it together involving the general manager, the oncologist, the accredited exercise physiologists, patient service officers, billing officers, centre leaders and operation managers, how they all have to work in a coordinated fashion to make this happen in terms of the implementation. And also from this paper here, the matrices of change objectives as well. So this, I won't go through them in detail, but there's some very helpful information there on how you actually implement an exercise oncology program within a cancer centre. So I'm going to move along just quickly now to finish off. I just talk about a few things, what's sort of really taking up our energy in terms of our focus around our exercise trials, our intervention trials, but also our clinical practice. And I've presented this before, but increasingly we're using high intensity interval training. Alternating work and active or passive rest intervals, adjusting the work and rest durations, really to target particular energy systems. And more, and you've seen from those early mechanistic and cancer biology slides that it really does seem to be the intensity of exercise, whether aerobic or resistance exercise, that we need, rather than volume overall, although that may change in terms of muscle hypertrophy. So we're using HIIT to be able to achieve those high levels of intensity. To the main, it's safe and well tolerated in many patient populations, if appropriately supervised. That's important. You can incorporate resistance exercise. We are using high intensity resistance training, or HIIT, as well. Something that we're using increasingly in our clinical practice and also our exercise trials is cluster sets. This involves short rests between repetitions during an actual set. For example, resting for 10 to 20 seconds between 1 to 3 repetition blocks, but you're still achieving 10 to 12 repetitions for the overall set. So a typical cluster set, you might do 3 times 2 plus 2 plus 2 plus 2, with a 30-second intraset and a 60-second interset rest. And we can see some examples here of how that might be actually prescribed. The advantage is it allows greater weight to be lifted within a given set. It's also useful for patients experiencing disease or treatment-related fatigue, and we're finding this quite effective for patients who are, of lower capacity, who are more frail. It is quite effective. Another exercise prescription parameter that we are implementing is accentuated eccentric. This is where the force generation is greater during the eccentric phase. And we're using very highly specialized equipment called the biocircuit from the Technogym company, and I've got to acknowledge their exceptional support for our research program. But these devices are actually computer controlled, and they're electromechanical, so you can control infinitely the type of resistance. And what we're doing is that we're providing perhaps 30 to 50% greater force or resistance on the lowering or eccentric phase compared to the concentric. Now, eccentric exercise produces greater force. You can do more force when you're contracting eccentrically, but it's also less metabolic and cardiovascular demanding. It has a strong anabolic drive for muscle mass, strength, but also in particular for fast twitch muscle fibers. It's less dependent on the testosterone pathway for anabolic and muscle hypertrophy. So we're using this in particular with men that are on testosterone suppression. So we're exploring this because we believe it could have considerable potential for patients with sarcopenia and or cachexia. Just want to finish off now with some discussion around telehealth. And look, wow, what a funny period we're going through. What a strange year it was last year. And I've got to be honest, it doesn't seem to be improving too much this year. So we're going to have to get used to it. We're going to have to adapt. Now, COVID, like all of you, forced us to pivot. We had to change all of our clinical services and our research trials such that our assessments and interventions were delivered remotely. We implemented home-based programs, but as many of you know from very good research studies and some of our own where we've implemented home-based programs, they're relatively unsuccessful compared to face-to-face programs. So how do you actually address this disparity? Well, clearly what we did was we actually drew on digital e-health, telehealth here, to try and roll out as high a fidelity and safety programs as we possibly could to our patients. And it's again though, it's important even without COVID, because access is a major barrier for patients in terms of broad exercise oncology access, and in particular those that are in rural, regional or remote areas. So we really need to get up to speed with telehealth exercise medicine, the assessment, prescription and monitoring, and implementation of wearable devices such as, I'm not pushing Apple or anything, they've surely got enough money, but devices like the Apple Watch and others, Fitbit, etc., for wearable technology where you can monitor. And these devices now not only give you physical activity and movement counts, distance as well through GPS, but they also can provide very accurate heart rate and also O2 saturation, even blood pressure. And also other Internet of Things biometrics. Many devices now, blood pressure monitors, body composition, etc., will be Internet linked. And during testing, they just shoot their data straight up to the cloud for monitoring and post-analysis. So just to finish off with one last slide about clinical application, I just want to reiterate the importance of periodization in terms of your exercise prescription. I think we have to separate out the aerobic and resistance training modes. The further we do in terms of trials and clinical practice, we're seeing that aerobic exercise in particular interferes with strength and muscle size gains. And so in particular patients, in those with sarcopenia, cachexia, those where their immune system is really compromised, they have difficulty responding to different modes at the same time. So you need to separate them out into either different sessions or even into different weeks. You need to change emphasis across the week, the month, and then across 12-week periods, and cycle your exercise volume and intensity with other treatments and their side effects. For example, we will build up intensity leading up to a chemotherapy infusion for a patient and then back it off after the chemotherapy infusion when they're suffering the toxicities of treatment. We do a resilience check each session. So when they come in, we ask them a series of questions. How well did you sleep? How is your pain level? How much fatigue do you have? How awake do you feel? And lively and motivated do you feel? And then we'll adjust the session prescription for that day. So this is called autoregulation, where you work with the patient, adapting the exercise prescription to fit with how they feel on a particular session. Dropping the load down, the intensity and volume when they're feeling poorly, ramping it up when they're feeling a little bit sharper. It's probably better to provide smaller, more regular exercise doses. and of higher intensity. And it's coming back to those, what I showed you earlier with those cancer cell suppression trials there. It's probably better to try and maintain those anti-tumor medicines, those cytokines and hormones, maintain them in your blood as much as you can throughout the day. So it's probably better to do shorter sessions every single day or several times a day rather than just do all your exercise on 2 days of the week. Regular monitoring and prescription adjustments important. You have to adapt it and keep it changing. Look, at the moment, face-to-face exercise is far more effective, and that's just because the equipment's better, the motivation for the patient is better, they've got someone standing in front of them. But COVID, if nothing else, has really increased our capacity around video conferencing, video chat. It's increased our capacity around telehealth, and we need to start really utilising the advances in technology there to provide more remote supervision to make access for patients much, much better. And I just want to finish off by saying I don't believe that exercise is physical activity. It is a type of physical activity, but it doesn't necessarily have to be fun. Exercise is a medicine. I think more and more we're seeing that it's absolutely critical for people with cancer. Chemotherapy is not fun either, by any means. And whilst we do know that exercise will not have serious adverse effects, it will not be overly unpleasant, there may be some exercises that the patient will have to do, which mightn't be great. I exercise every day, but I must admit sometimes I'm sitting in there lifting weights or working out hard on a bike or a treadmill. I must admit I'm not loving it. I'd rather be home, sitting at home reading the paper. But the patient, I think we have to get that message across. Look, you're in here. We need you to exercise hard at a fairly high intensity because that's going to produce these highly protective anti-cancer medicines for you. So I want to thank you for your attention today. I really appreciate it. Again, I acknowledge the support of Genesis Cancer Care and the opportunity to present this webinar. There's our website. There's my email. Please feel free to contact me, and thank you for your attention.